Today on the LowDOWN, a Down syndrome podcast, Dr. Natalie Baldauff gives us a lowdown on endocrinology and Down syndrome. Over to you, Hannah Mala.
Thanks, Danielle. Hello, everyone. My name is Hannah Mahmoud, and I'm joined by my wonderful co-host, Marla Folden, and welcome to another episode of the LowDOWN podcast. On today's episode, we will be switching gears towards a medical topic and focusing on endocrinology with an expert in this field. Dr. Natalie Baldauff is a physician in the Division of Pediatric Endocrinology at Children's Hospital of Pittsburgh, where she serves as the Director of Metabolic Bone Disease Clinic. She completed her pediatric residency at Wright-Patterson Air Force Base, Dayton Children's Hospital, and her endocrinology fellowship at Children's Hospital of Pittsburgh. She also completed an executive MBA in healthcare administration at the University of Pittsburgh in 2022. Dr. Baldauff is interested in the care of children with hereditary and acquired bone disease, including metabolic bone disease of prematurity, osteogenesis imperfecta, and Duchenne's muscular dystrophy. Dr. Baldauff, thank you so much for joining us and welcome to the LowDOWN.
Thanks so much for having me. I'm excited to be here.
Thank you.
Okay. We are also super excited to have you here. And in the grand tradition of this podcast, we start with a few secret questions. So I will get into those for you. They're fun, promise. So the first question is, if you could add an additional holiday to the year, where would you put it and what would it be for?
Oh, wow. That's a tough question. So an extra holiday, I think, I often as a parent, I think struggle between like Thanksgiving and maybe Easter, because I think we are over holidayed at those times.
Mm-hmm.
So I think I would probably, do it in the early summer when my kids are off school and I actually have the time to enjoy things. I would definitely do it when the weather is nice. I would love like a pool opening party or an annual water balloon fight or something.
Love it.
that would fill in those like early summer gaps to get people together, because I think that's always a time of year when we should be doing more getting together.
I think that's a great answer. I want that to happen. I think that'd be really fun. My second question for you here is, do you have a favorite travel hack that you like to use?
Gosh, a favorite travel hack. We travel a ton. So this may be a good travel hack for parents of young kids. So when our kids were little, we always traveled with car seats. And, it's a really pain in the butt to push your car seats. And so my best parenting travel hack is they sell these little things that turn car seats into rolling luggage. And so we would just like strap our kids in there when they were little and push them through the airport. And it was really a lifesaver. So that was when my kids were little, best traveling hack.
Such a good idea, because you just don't have enough arms to manage all the equipment. That is perfect. Then you don't even need a strap.
Yeah.
That's amazing.
Right. And then you all have your car seat when you get off the plane, and you just put it right into your rental car if you're renting a car, and you don't have to worry about that. So, and then I think kids also behave a little better when they're strapped into their car seats on flights as well, because they think it's like the car. So my kids are big now. We don't do that anymore, but that was my best kid travel hack.
That is brilliant. I'm going to use that in the near future. Last question here is, if you could name a band, what would you call it?
Name a band? Oh man, these are hard questions, guys.
We've been around for a long time. Ice cream flavor, we asked 8 seasons ago. We got to get in the good stuff here.
Yeah. So I'm a big gardener, so I love flowers. So one of my favorite flowers are like dahlias. So I might call the band the Dahlias. That one of you. That would fit me well.
That is a great name for a band. Yeah. I love it.
Very nice. I feel like I know you a little bit as a person now. That's wonderful. Let's start talking about endocrinology, and we're going to start at the very beginning. So for those that are unfamiliar, can you tell us a little bit about what an endocrinologist does in the healthcare system, and like, when do people call you? What's your role on a patient's healthcare team?
Sure. So I'm a pediatric endocrinologist, but most endocrinologists, you're going to either have pediatric or adult specialists. So a pediatric endocrinologist is somebody who's done a 3-year pediatric residency and is board certified in pediatrics, and then does an additional 3 years of training in this field of endocrinology. So we specialize in kind of hormonal disorders, but that's very broad. So we take care of patients who have diabetes, type 1 and type 2, or other blood sugar issues, as well as other hormonal issues such as delayed or early puberty, abnormal thyroid function. As you guys noted before, my subspecialty is bone disease. So I take care of patients with osteoporosis and other disorders of bone health. And we would see a patient usually after their pediatrician or other specialists has identified a problem involving, something that we take care of. And then we would see those patients in our, subspecialty clinic.
Super. I think that gives people a good kind of picture, or a really wide angle picture of what your role is. And I think we should also talk about what is the endocrine system? What are hormones? Because I think people hear hormones and then they just think puberty, and it's actually much broader than that. So let's talk about what are hormones? What's the endocrine system?
Yeah, so our endocrine system involves a lot of different things. So if we want to think about just more, in terms of hormones that would come from our pituitary gland in our brain, and that's kind of, we sometimes in old days we used to call that the master gland, but that's a gland that sits in our brain that makes a variety of hormones that help with different things about our body's function. So it makes growth hormone, which promotes growth during childhood. It makes the thyroid stimulating hormone that talks to our thyroid gland. It also makes our puberty signals, FSH and LH, that tell the ovaries and testes to kind of make hormones at the times of puberty. And then you're just going to make a hormone that controls our adrenal glands. And so one of the really cool things about endocrinology is it's all very logical, right? Our brain sends signals to our organs, and those organs make hormones that help us to grow and develop appropriately. And typically, if there's a problem in that feedback loop, right, then that's where our patients typically are developing some symptoms and then coming in to see us. The endocrine system also involves, our blood sugar management, which involves kind of our insulin production as well. And so that's really relevant to our patients with Down syndrome in many cases. And so that's important to note as well.
You led me perfectly into our next section. So endocrinological concerns are more common for people with Down syndrome, as we've kind of touched on. So our plan for this section was to do a bit of a rundown of what kinds of concerns are coming up more often, and maybe why they're coming up more often in this group of individuals. And we'll kind of go from there. So what do you think would be the most appropriate one to start with?
So I think probably the most common thing that we see in individuals who have Down syndrome is our thyroid dysfunction. That's probably the first thing that patients would see. And that's something that the parents would probably learn about first, because it's usually the earliest thing to present. So I think thyroid dysfunction is probably the best place to start.
Okay, let's talk about that then. What's the thyroid? What's it supposed to be doing? And what does it look like when it's not functioning correctly?
Sure. So our thyroid gland is this little butterfly-shaped gland that sits in our neck, and it makes a hormone called thyroxine, or thyroid hormone. And that's responsible for a lot of, metabolism, a lot of the body's normal metabolism. So you need, particularly important for babies, you need thyroid hormone to have normal cognitive development. You need thyroid hormone to have normal growth. Babies who have hypothyroidism might have more, constipation or poor growth, poor waking. They can definitely, cognitive development is affected. So all babies in the whole entire United States are screened for hypothyroidism on the newborn screening. So anyone that has kids remembers that little heel spot test that you do in the newborn nursery. And so that's kind of the first screening, and that's for everybody, right? That's not just for individuals, who have Down syndrome. Everyone gets that screening. And so that's sort of the first time that thyroid hormone is checked for all patients. And we do that because it's so important for cognitive development that we want, if those patients have problems with their levels of thyroid hormone, we want to know as soon as possible within the first week of life.
And is the problem at the organ of the thyroid itself, or is the problem the sort of communication between the pituitary gland and the brain and the thyroid, or the feedback from it?
Yeah, so more commonly, both can actually happen, but more commonly, the most common reason why an infant or baby would have hypothyroidism is because of underdevelopment of the thyroid gland. So in the general population, there are really 3 reasons why babies would be born with congenital hypothyroidism. One is that the thyroid gland is formed normally. So if you looked at it on ultrasound, it would look completely normal, but it doesn't function appropriately. And that's actually the most common thing that happens in babies who have Down syndrome. That you can also have a absence of development of that gland. So when the baby was growing in mom's belly, the gland just didn't form, and that is another common cause. And the third option is that you can also have what's called a lingual thyroid gland. So the thyroid gland formed appropriately, but as baby was growing in mom, the thyroid gland has to kind of descend from the base of the tongue into the neck. And if it doesn't do that, it doesn't form into like a normal healthy gland. So it's not able to make enough thyroid hormone. So those are really the 3 options. But for babies that have Down syndrome, the most common reason it tends to be what we call like thyroid hormone, abnormalities in production of thyroid hormone. And that's, so most of those patients have a normal appearing thyroid gland in the neck.
So just to be clear for everybody, we've been talking about probably hypothyroidism,
right?
Which people would receive a medication for, which we'll get into a bit later. But there are other concerns around the thyroid gland that do come up in maybe smaller subgroups of the whole group of people with Down syndrome. And those include things like Graves' disease and Hashimoto's thyroiditis. Do you want to cover one of those next?
Yeah, sure. So after congenital hypothyroidism, then the next most common thing we see is acquired hypothyroidism, which you already touched on, and more commonly, that's related to Hashimoto thyroiditis, or what we would call, acquired autoimmune thyroiditis. And so this is an autoimmune disease that affects the thyroid, that affects the thyroid gland's ability to make thyroid hormone. And so you end up with an underactive thyroid gland that would require the same medication that you would need if you had congenital or you had newborn acquired hypothyroidism. And those are patients with acquired hypothyroidism, which typically present a little bit older. And sometimes they're having symptoms of, slower growth in height or constipation or drier skin or changes in hair. But many times, because our physicians that take care of patients with Down syndrome are usually so excellent, we're usually picking this up on their annual screening. And sometimes that's the goal, is to find those problems before patients ever have symptoms, because we know it's so prevalent in the community.
And this is one of those reasons for that annual, very dreaded, but very important blood tests. Just to check on things and see how it's going, because as we know, our students don't necessarily tell us when they don't feel very well.
That's right.
Can we talk about Graves' disease a little bit?
Absolutely. So Graves' disease is, really a different kind of autoimmune thyroid problem. So in Graves' disease, you have basically an antibody that talks to the surface of the thyroid gland. We call that the TSH receptor antibody. And it basically turns that thyroid gland always on. So in a normal situation, one of the analogies I love to use is, if you think of your brain, it's kind of like the thermostat of the house, right? And your thyroid gland is the furnace. In a patient who has hypothyroidism, right? If the house is cold, so your furnace isn't working, the brain turns up that TSH and it, tries to kind of make that feedback to make the gland produce thyroid hormone. In a patient who has Graves' disease, what happens is, it doesn't matter what's happening in the brain. That antibody turns the furnace all the way on and like up to 1,000 degrees, right? So you're basically independent of TSH. You're basically overproducing thyroid hormone. And that leads to, those symptoms of overactive thyroid gland can be unintentional weight loss, or very like rapid heart rate, because your metabolism is kind of in overdrive, essentially. You might have diarrhea. Patients might be more anxious or sleeping poorly. And a lot of times, we see a lot of kids that just have behavior changes, and parents are, what is happening?
Yeah. And those kids are hungry. Those kids are
hungry.
So hungry.
But
right?
They're weight.
But they're little rail thin little ones or teenagers, but they don't stop eating. They're so hungry. That's a big telling. And you can see it in somebody's eyes a little bit, and what's going on with like their eye sockets. It's a wide ranging thing.
Dr. Baldauff, I'm just curious. So because, considering there's a congenital and an acquired, and then of course in adulthood there's thyroid disease as well. And of course we know that thyroid checks are part of the healthcare guidelines, that Marla and I talk about the healthcare guidelines any opportunity we get, because a lot of our families don't know about them. Do Do you think a yearly checkup is enough, or does it depend on the child or the patient in terms of how often they should get their thyroid checked to keep track of everything?
Yeah, so yearly is usually enough. So in the first year of life, as I mentioned, we always check on newborn screening, and then babies should be checked at 6 months and then again at 12 months for hypothyroidism, because again, that thyroid hormone is so important for cognitive development for patients. And then after that, once a year. But definitely, we often screen in between. So if a parent comes to us and says, hey, we've noticed these changes in our kid, we've never had problems with constipation, but now this is really a difficult thing for us, or there's behavior changes. Certainly with Graves, it's much more obvious. Patients, often have a lot more symptoms. And so if anybody would present with those symptoms, I would encourage any provider taking care of a person who has Down syndrome to have a low threshold to check, because we know that the risk is high. And so that's where I think educating families is so important, because the more families know and understand, the more likely they are to advocate for their children.
And just in my clinical experience working with lots of families who've gone through this, it seems like Graves' disease is a little bit more difficult to manage and titrate that medication. We see a lot of yo-yoing.
Yes. Graves is much more difficult to manage because it can be a little bit unpredictable. I mean, the drug we use is called methimazole, or the brand name is called Tapazole. But there are more side effects with that medication, and it doesn't always work in every patient. The goal is that it works, but oftentimes if it doesn't work or patients are having side effects, we have to move to other therapies, like using radioactive iodine to kill that thyroid gland. Or if a very, very young child has Graves' disease, we don't typically use radioactive iodine in children who are young, like under the age of 5 years. And so sometimes those patients have to have actually their thyroid removed if Graves' disease can't be controlled with medication. So it definitely is much more difficult to control.
So closer management for that whole scenario. Essentially, they'll be seeing people a lot more regularly while they try to get that managed. Let's shift gears here a little bit away from the thyroid. Let's look at insulin. Let's look at diabetes here, which is also more common in people with Down syndrome. We're talking largely, I think, about, type 1, type 1.5, and type 2. You have
Yes. And so both the type 1 and type 2 diabetes are more common in patients with Down syndrome. And people will notice a theme that there's, more autoimmune disease in general and people with Down syndrome. And the kind of interesting fact there is there's a gene that's on the 21st chromosome called our AIRE gene. And that is a gene that, if that is mutated or abnormal, can place patients at risk for autoimmune disease. And so there's some suspicion that that may be a factor in why patients who have Down syndrome do have, more frequent autoimmune diseases. So yes, so type 1 diabetes is more common. And then, patients with having type 2 diabetes is also more common. And I think that's when we kind of get into the conversation about sort of the importance of healthy habits and weight management as well, because we know that obesity and abnormal weight gain is a risk factor for type 2 diabetes.
Let's talk, as I think people are more familiar with diabetes and what happens and what to do to manage it. So I'm not going to stick on that one for too long. Sure. I wanted to talk a bit about alopecia and alopecia areata in particular, which is common in this group. What do you want to note about that?
Yeah, so I mean, this is another one of those autoimmune diseases that's a little bit more common, and and this can be very difficult to treat. And I think one thing that we always see in endocrinology is we're not usually the primary ones managing alopecia. If we see alopecia, we're typically involving our colleagues in dermatology to kind of help manage that. And there are, and one of the things that patients often ask us is we often find that patients with alopecia often have thyroid disease as well. And so a very, very common question from parents is, well, if we treat the thyroid disease, is the alopecia going to get better? And my answer is always not necessarily. I tell patients that it's, these are two things that both can occur in the same person and are not, and can be related because they're both autoimmune diseases, but one doesn't necessarily always cause the other. And normally, we involve dermatology early. Sometimes dermatologists will do topical or intralesional steroids for kind of small areas. But for widespread alopecia, it can be a little bit more difficult to treat. And I think that's an important conversation for patients to have with dermatology. And it also really is important for patients to know, like families to know how aggressive they want to be about treatment. It might be very difficult for some young kids to have like steroid injections in areas of alopecia. And that's challenging. So I think that really is like a shared decision-making point with the family as well.
Mm-hmm. And alopecia, if I'm not wrong, can follow different trajectories. Some kids will have one instance of alopecia and then never again. Some kids will go basically fully bald for a while and then grow their hair back, and then it will happen again. And we often see these things in relation to like stressful life events is a big concomitant thing, not necessarily a cause, but happening at around the same time. Are you more or less likely to be involved in like additional rounds where people are looking further into more autoimmune issues?
Yeah, I mean, I think that we tend to, I think we tend to kind of see the patients who are dealing with that, just because a lot of times patients who have alopecia also have other autoimmune diseases that we are managing. Or, I will say we see them a lot in endocrinology whenever dermatology may see them first. And dermatology may check thyroid antibodies and say, oh, this patient has thyroid antibodies that are positive. And we'll say, well, yeah, that often happens. And so that's sometimes how we get involved with patients. I have had a few patients who have been treated by dermatology with steroids or with like oral steroid courses. And, as the oral steroids long-term can affect our function of our adrenal glands, we do, as endocrinologists, like to be involved in that as well to make sure that we're protecting and watching that adrenal gland function for patients that are on steroids. So that's kind of how we ultimately get involved. I don't think any of us in our specialty really directly manage alopecia, but we often, because especially for patients that have hypothyroidism and diabetes, we are seeing these patients more often than their PCPs a lot of times. And so sometimes we're the folks that are picking that up and kind of directing them to the right path. And it's very true. Sometimes you have a very small area that goes away and never comes back. And some patients develop alopecia, totalis, where they're losing a lot of different hair. And it's really hard for us to predict the course for families.
Yeah. And families really do differ in the amount of stress that they experience around that.
Sure.
It's a big deal for families. Let's talk the last kind of subject area that I wanted to cover in this initial part was vitamin D deficiency.
Sure. Yeah, so we definitely do see vitamin D deficiency very frequently. So there are a couple risk factors here. One is, a lot of times, if you live in Pennsylvania, like we do, right? There's 6 to 7 months out of the year where we're not making vitamin D from exposure to the sun. And so, you have to have adequate dietary intake. And as, we see across all children, but sometimes particularly children who have, any like particular food aversions or picky eaters or have a very narrow palate, it's sometimes often very hard to get vitamin D from the diet. Our main dietary sources of vitamin D for most kids are going to be milk. But if you can't handle lactose or you aren't a milk drinker and you're not having other foods that are naturally occurring sources of vitamin D, it's pretty easy to have, lower levels. Additionally, patients who have Down syndrome have a higher risk of celiac disease as well. So they may have some malabsorption related to celiac if it's not been diagnosed that can also contribute. So, and then we know that, individuals who are overweight or obese tend to need more vitamin D than patients who are lean. That's kind of, something that we know because it gets almost, we think of it as sequestered in adipose tissue. So the needs tend to be higher. So the big concern with vitamin D deficiency is, that over time, right, you need vitamin D to absorb calcium and phosphorus from your gut. And so if you, particularly for small children who have very severe vitamin D deficiency, you can develop something called rickets, which is where your bones aren't getting adequate calcium and phosphorus. And that can cause, poor growth. It can cause problems at the growth plate. Kids can have like bowing of their extremities from kind of softer bones from not mineralizing appropriately. And it can be, I have seen a few patients in my Down syndrome, population who have had pretty severe vitamin D deficiency and secondary vitamin D deficiency rickets. So it is important that, families know that children should be getting, adequate dietary sources of vitamin D. And if they're not having foods that have supplemental vitamin D in them, then, taking a supplement is recommended. So most of the time, a multivitamin that you would get over the counter, recommended daily allowance of vitamin D is 400 international units per day. Though some kids may need more if they have malabsorptive conditions or they don't eat well, or some people may need more. But it's a very easy thing to add on to those annual labs if there are, dietary concerns.
Yeah. And I think it's one of those things that is often overlooked, but it can make a very big impact as well in terms of your overall well-being and your overall health.
Sure.
So, especially, and I like that you mentioned that, of course, with vitamins, the go-to is always to be able to get it as naturally as possible through the foods that we eat. But of course, we know that with people with Down syndrome, like diet, feeding, there's challenges that happen there with gut issues. There's challenges. So that may not always be the case and might be further overlooked because, you're just assuming that, vitamin C and B we all have. But, the D is also really, really important to kind of consider as well. So, yeah. Okay, so let's move over to, is there any other disorders or conditions that we may have left out that you think are important to cover? Or do you think we've covered a good basis?
Yeah, so I think we've covered. I think the other, like the older things are that some things I think you don't think about, but like low hormone, like hypogonadism or low estrogen and testosterone levels in adulthood. I have found that when I have made that diagnosis in patients, I think that some families are really surprised. So I wonder if that's an under discussed topic. And I'm interested to know what your thoughts are about that. But I've found that might be occasionally a topic that's not discussed as often, perhaps because we're so focused on the little ones that's not it's a more discussed topic.
Yeah, or that thyroidism and diabetes somehow just seem to take precedence in their minds too, because it is something that is outwardly affecting their daily functioning. Yeah. So I haven't really had very many conversations with families. I don't know, Marla, if you have about.
Oh, not very many actually. That's a really good point. What would be some of the clinical signs that someone would perhaps notice that would indicate that they should come in or get some labs done?
Yeah. So one of the things we see, I would tell you the way I've picked up, especially in males, is that, when males are going through puberty, right, we see, kind of a progressive enlargement of the testicular size as kids go through puberty. And sometimes one of the ways I've picked up some, early, hypogonadism, changes are that if you're, you have those two signals from the pituitary, FSH and LH, that talk to the testes. So FSH is primarily responsible for growing those Sertoli cells, and that's what produces semen in males, and then LH is primarily responsible for growing the testosterone producing cells. But those semen producing cells or Sertoli cells are the bulk of the size or the volume of the testes. And so the way that the providers would pick that up is that you would see lack of kind of testicular enlargement through puberty. And occasionally we see that. And I think, one of the things I always tell my patients is that, yes, it's never comfortable to have those checks, right? Kids don't love it. But we want families to know that it's just as important that we check puberty as kids are growing as it is that we check their heart or check their thyroid, because we want their bodies to overall be healthy. For women, obviously, it's a little bit easier. We can't see their gonads, ovaries on the inside of the body, not the outside. So for women, we would know that, based off of kind of pubertal arrest, or if they had irregular menstrual cycles, are the ways we would see that in adults. And it is, a well-described thing. I tend to see it a little bit more commonly in males than females. That's been my experience. Yeah.
Just maybe almost unfortunate, because I think families pay a lot of attention to menstrual cycles for their teens and young ladies, because it is such an involved process, and there has to be so much preparation. Like that, people are aware of that cycle, but maybe not for the males. Okay, well, that's a really good note.
So Dr. Baldauff, now that we've gone through all the endocrinological concerns, let's talk a little bit about treatments. You mentioned a little bit about some medications for thyroid. We know there's medications available for diabetes. Is there any change in efficacy of treatment due to the component of Down syndrome? And then apart from medications, are there other things that families can consider in terms of helping deal with each of these conditions?
Sure. So for hypothyroidism, the main treatment is going to be levothyroxine for these patients. And so this is basically a synthetic form of what the thyroid gland would make. Just some basic things for families to know. We most endocrinologists will tend to recommend a brand medically necessary for young infants, because can be a lot of change in sort of genetic and then generic preparation that, we want. So most of us will recommend for the first 3 years of life that the kids are on like a brand medically necessary. It doesn't have to be brand Synthroid, which is the one most people know, but a consistent brand is important. I've actually been using quite a bit recently. There's and now in the past few years, a liquid preparation of thyroid hormone, which I think has been life-changing for some babies who don't take meds super well. Yeah. Because remember, even babies with hypothyroidism, before we had the liquid preparation, which is called Tyrosint, available, we had to crush these medications and mix them with a small amount of water. And so I think it seems simple, but it actually can be really hard for families to do that. Yeah. And it's so important that those meds are given every day, that, if insurance will cover it. I really had a lot of families find that they love the liquid preparation. I think it's a good thing for people to talk to their physician about, because if their insurance will cover it or they have the means to pay the higher copay, it may be an awesome option. And it definitely is much easier.
That's a good note, even for the older children who have a history of feeding tubes or whatever other issues with swallowing, that powder or mixed with water might not go down so well. Yeah.
And so, and the nice thing is, some of the brand names, like brand Synthroid in particular, like it isn't a very bitter medication. So actually, a number of my patients just chew it and they do great with it. So so I always tell them when they're old enough to chew a cookie, I tell them, hey, try to have them chew their medication. The goal is we want to get it in every day, but we also want to make their life easier. That's, really important. And that's going to be the mainstay of treatment for hypothyroidism. A lot of families ask us about sort of alternate preparations like Armour thyroid or like natural thyroid. And, we do not recommend those in young kids, keeping in mind that some of those thyroid hormones are essentially like crushed up pig thyroid that contain T4 and T3 and kind of unknown maybe amounts. And so we really discourage families from using those because it's really not safe for young kids. Definitely adults may make different decisions, and we all respect that. But for young kids, we truly recommend using levothyroxine alone for little ones, especially when they're growing. So that's kind of mainstay for hypothyroidism. As I mentioned, with hyperthyroidism, the mainstay of treatment is methimazole, which is anti-thyroid medication. And, that this is also a tablet form. So we would have to crush and mix. So it's also, there's some inherent challenges there. Different from levothyroxine or Synthroid, which is dosed once a day. Methimazole is dosed usually 2 to 3 times per day. So an added layer of challenge for families there. And that medication does have some side effects. You can have some rash or some joint aches and pains. There's a risk of some liver dysfunction with that medication, though very rare. We really watch for those things as we're following kids on therapy.
That dose frequency really says something about the difficulty of management.
Yes.
Yeah, and that's the side effects. Yeah, the side effects are also, and that's the thing is with medications, it's so tricky because for a lot of us, we need the medication, but then sometimes the side effects, it's just difficult to continue with a proper regime with your medication when taking it is going to result in this, maybe not so good feeling in your body. So
I would say, with methimazole, I think most kids don't the good thing about it is if kids have side effects, they are usually bad enough that we say, okay, should we be taking this medication? And if they don't have side effects, they actually tolerate it very well. So it tends to be a very, for good or for bad, a more black and white,
dry,
thing, which, I think it's not necessarily a bad thing, but we do feel it's important for families to know.
Yeah. And then, of course, we know that with diabetes, generally for level 1 or type 1 diabetes, often it's, insulin is the go-to prescription.
Right.
And so, just a little bit about diabetes medications for type 1 and type 2 in relation to, to Down syndrome as well would be.
Yeah. So, for type 1 diabetes, the treatment's going to be insulin. But I think really the thing to know in 2024, we have so many ways to make diabetes management easier for families. And that is really amazing, right? So one of the things that makes diabetes management so hard is, the number of times a day we have to check blood sugars, right? Poking kids' fingers 6, 8, 10 times a day is so difficult. But now, we have continuous glucose monitors that a child can wear that can monitor blood sugars every 5 minutes,
Yeah.
and families can definitely do multiple daily injections with long-acting insulin that kind of covers the person all day, and then short-acting that they take for meals. But we also, children with Down syndrome, just like any other child, can use an insulin pump for management of diabetes.
Yep.
And that can really be life-changing for families because it, minimizes the number of, painful things that has to happen to the child during the day. And we now have multiple pumps that have what's called closed loop insulin delivery. So that's where the continuous glucose monitor talks to the pump, and the pump helps to adjust the insulin throughout the day. And so I think that it's a great, there's not that, we ever are happy when the child has diabetes, but I think what, when I would focus, the positive end of that is we have so many great ways to manage right now that we didn't have 20 years ago, or even 10 years ago. Closed loop insulin delivery wasn't a thing. So
yeah, it's true. Yeah, if you're going to have it, 2024 is a pretty good year to have diabetes.
Yeah, and I think those systems are great because we have some students that are older, but it's really great because it kind of instills that sense of independence in managing it yourself as well. So it's something that they can be taught to manage as they get older on.
Yes.
Just makes it so much easier, and there's just one less thing, a caregiver will have to constantly worry about.
Yeah. And some of them come with peace of mind for parents. There's Bluetooth alerting systems to your phone, all of that kind of thing, which is really, really nice because diabetes can be really scary.
And then with type 2 diabetes, Dr. Baldauff, is it mostly just medication that anyone else would use that would be used for people with Down syndrome as well?
Yeah, absolutely. So, type 2, the way we manage type 2 diabetes really depends on what your hemoglobin A1C, that's that kind of average blood sugar, is when you're diagnosed. So, for patients who have a very high hemoglobin A1C at diagnosis, those patients may actually need insulin just like a person with type 1 diabetes. But for patients who present with less severe hyperglycemia, who have a lower hemoglobin A1C at diagnosis, we're generally starting patients on treatment similar to patients who do not have Down syndrome. So metformin is usually, the standard of care to start. And, we also are using medications like which most people know, it's very jazzy in the news now, like the GLP-1 agonists. So like Ozempic and, and Victoza and Trulicity and some of the GLP-1 agonists. And those medications, we use those as well. And they can really be very helpful because they have that added benefit of helping with weight loss, which is really a troublesome thing for some of our patients.
Yeah. What are your thoughts on, I know we mentioned briefly about vitamin supplements, but sometimes there's additional supplements that families are asking about in terms of hormone balances and additional mitochondrial issues. I'm just curious, what are your thoughts on what families should think about before researching or trying any particular supplement to help with some of these?
Yeah, so I definitely would say they should be discussing whatever they're going to start with their providers, because, the supplements are not a regulated item. And so it is very possible to buy or purchase something that, might not actually be in their best interest. And sometimes it's not always clear what's in those supplements. We have had, just in a general endocrine, practice, we've had patients who have taken medications that had much higher doses of vitamin D than they knew about, or things that affected other parts, other labs. So, for example, some of these supplements that are very high in biotin, which a lot of people take for like hair, skin, and nails. I've definitely had patients with alopecia want to take biotin. Well, if you are taking biotin, it actually can interfere with the way we measure thyroid hormone in the lab. So it can screw up your thyroid hormone test measurements. So I would recommend that, any supplement somebody wants to take is worth a discussion either with their primary care doctor, or if they're seeing endocrine. I'm always happy to look at those supplements because they are not always helpful and they sometimes could be harmful. And as long as people are aware that it is, it's not a regulated item, I think that's really important.
Yeah, absolutely. That's a really good point.
Yeah, I think so too. And I mean, what we mean by not regulated is that there's no rules around how potent something is, how the consistency, bottle to bottle, brand to brand is not there. There are not rules on it. So you might buy something once and it would be one way and another time and it would not be the same. And that would be a problem.
And I think one of the ones that families are probably using now, not knowing that it's not regulated, is often melatonin, right? So at least in North America, it's not regulated.
It's not regulated. Yeah. And melatonin is generally safe, but I think making sure there's I've seen some of the melatonin supplements, even, my daughter takes it occasionally at night, that some of the brands have other things in there, right? So it's not just melatonin. And so it's never a bad idea to double check with, to look at the bottle, to send. What I do for my patients, we have this, great patient portal system. If someone sends a message and says, hey, would you look at this? 100 times out of 100, I would rather look at what's in there and say, okay, this looks fine. I think this is okay. Let's stick with this. Or, maybe this is not a great idea. So
yeah, exactly. And it's just good to know, because it is something that a lot of families rely on to help their kids with their sleep issues. But it's just good to know, it's kind of a buyer's beware situation here, just so you know what you're getting. Dr. Baldauff, just kind of wrapping things up, from your perspective, do endocrinological issues change with age? Are there things that we might need to think about for adults and their issues with the endocrine system versus when we're working with younger people?
Yeah. So, I definitely think all of these issues change a little on how we monitor things with time and with age, right? So young kids, for example, with hypothyroidism are going to need to be monitored much more frequently. They're going to need much more frequent dose adjustments. Adults will still need lab draws into adulthood, and they'll still need monitoring into adulthood, but they may not need as frequent monitoring if they've been stable, for example, stable on a thyroid dose for many years. They may need less frequent lab draws. And then in terms of, diabetes care is going to probably be the same throughout the lifetime for all patients. The American Diabetes Association recommends that patients are seen every 3 months or 4 times a year. And, we would continue to recommend that into adulthood.
Mm-hmm. Can somebody outgrow an endocrinological issue? So, for example, if they have congenital hypothyroidism, are they having that forever, or could they possibly grow out of it?
Yeah, so congenital hypothyroidism is less likely. So if the child's born and they have a very high TSH, right, that's very unlikely, if not impossible, to grow out of. The only time we do see patients kind of grow out of hypothyroidism is occasionally we'll see young kids with a very mildly elevated TSH. So generally speaking, most endocrinologists are going to initiate thyroid hormone replacement when the TSH, which generally normal range is about, depending on the lab, 0.5 to 5. Normally, we are recommending initiation of thyroid hormone replacement when the TSH is greater than 10, and thyroid hormone levels are kind of low normal or low. We're going to treat. There's a group of patients who have what we would call subclinical hypothyroidism, where they have a TSH level that's mildly elevated and it's still maybe maintaining thyroid hormone levels themselves in the normal range. And there's a little bit of a debate in the endocrine and Down syndrome community whether you treat that or not, right? And so, there are some patients who have that subclinical hypothyroidism. They do tend to grow out of it in a sense. Sometimes it just gets better as they get a little bit bigger and they don't need medication. But generally speaking, if I am having that conversation with the family, okay, your TSH is 7, your free T4 is still normal, the child's growing well, not having any symptoms. I think the important thing to know is that we want to monitor that, because we would not want that to turn into overt hypothyroidism that ends up needing medication without us being aware of that. So that's one where sometimes if you see these mildly abnormal labs where thyroid hormone levels are still normal and kids are not symptomatic, there are a number of us who will monitor without therapy, provided the TSH is not continuing to trend up.
Mm-hmm. Okay. And so what would you, I know throughout this episode, we've talked about what signs to look for, but as a general piece of advice for families, what should they be looking out for that would trigger, I need to get my labs done? Yeah. Get my labs done.
Yeah.
An appointment or get a referral for an endocrinologist. Yeah.
Yeah. So let's start with diabetes. So patients with diabetes are going to be having, first signs of high blood sugar are going to be excessive peeing. Okay. So peeing a lot, particularly a child who was previously dry at nights, now getting up or wetting the bed. excessive thirst, right? Because your body's trying to get rid of excess sugar. So with the sugar goes the water. So excess peeing comes first, then excess drinking, getting up at night to drink or pee, and then unintentional weight loss. So if any of those symptoms are happening, really low threshold, super easy thing to do, checking a blood sugar, checking a urine sample, very easy in a PCP office and would very easily identify a problem. For thyroid, it's a little bit, I always tell families it's a little bit tricky because one of the things people always say are, well, they're tired, it must be their thyroid. And there's a lot of reasons to be tired that aren't your thyroid, right? Yeah. Right? So people with, particularly like children with Down syndrome, a lot of them struggle with sleep. Some of them have sleep apnea or sleep disorders. And so it's very hard. So making sure that someone is accurately measuring the child every year and making sure they're growing and following, Down syndrome specific growth charts. If growth velocity is slowing down, that's definitely a concern that, you have, overt hypothyroidism that needs to be treated. Worsening constipation for hypothyroidism, behavior changes, right? So sometimes these things can be very subtle. So behavior changes, poor linear growth, constipation, changes in the skin, hair, nails, those would all be things to say, maybe this person has hypothyroidism. And then hyperthyroidism, definitely, as we already mentioned earlier, like rapid heart rate, behavior changes, anxiety, unintentional weight loss would be, on that list. Very easy for families to check a pulse at home. If they notice that this child has like a racing heart rate when they're like chilling on the couch on their iPad, watching TV, would definitely be a red flag to come in to be seen. And, as we know, children who have Down syndrome do have shorter stature than the general population, but that doesn't mean they don't grow. So I really think that's, for PCP is, definitely watching and making sure that children are having an appropriate rate of growth, following Down syndrome specific growth charts for them is key, because you can pick up a lot of things just on the basis of poor childhood growth. So any poor growth that is, suboptimal from a, following Down syndrome specific growth charts should also be referred to us.
Mm-hmm. We can put some growth charts on this episode page too. I think parents can also plot growth and bring that in if they're concerned. It's just a little chart. We'll make sure that those are on this episode page. And
then we'll also add like the healthcare guidelines of the parent-only version of the healthcare guidelines, because it's nice. It's really hard to keep track of everything for parents, I'm sure. So it's nice to have it laid out in a way where they can be like, okay, thyroid needs to get checked, this needs to get checked. So all of those resources can be really helpful for sure. Yeah. Well, Dr. Baldauff, thank you so much for taking the time to chat with us today. This was so informative for us as clinicians. I'm sure families and caregivers that are listening are going to benefit greatly from, knowing what to look out for, knowing what issues to think about, and knowing when to worry and when not to worry. So all of those things are really, really important to know. So we thank you for your time.
Thanks so much for having me. This was great. It was a lot of fun to talk to you guys.